Acute respiratory distress syndrome. ARDS, or acute respiratory distress syndrome, is an acute respiratory failure, and it has some criteria to meet the definition of ARDS. We have hypoxemia, even though we are administering 100% oxygen. There is decreased pulmonary compliance. The client will experience dyspnea. They will have non-cardiac associated bilateral pulmonary edema, and they will have dense pulmonary infiltrates on the X-ray. ARDS usually will occur after an acute lung injury or other issues such as sepsis, burns, pancreatitis, trauma, and transfusions. Despite the cause, though, the similars of ARDS will always be similar. So what happens with ARDS? Well, the main injury site will be the alveolar capillary membrane. Usually this membrane only allows small molecules to pass through, but with injury, it becomes more permeable and now allows larger molecules to pass through, such as debris, proteins, and fluid. And this goes directly into the alveoli. Fluids and proteins will then increase in the lungs, which are normally dry, and this exudate will inhibit gas exchange. The second issue with ARDS is going to be a decrease in surfactant production. Surfactant is a substance that increases lung compliance or elasticity and recoil and prevents alveolar collapse. The surfactant that is present is now diluted with excess lung fluid, and it will allow the alveoli to collapse, so now they're unable to participate in gas exchange. Edema also occurs around the terminal airways, and this compresses and closes these areas, creating more tissue destruction. Alveoli that have not collapsed are continuing to receive blood, but due to the edema and due to the fluid, they are unable to shift oxygen into the blood. The actual number of ARDS cases is not really clear because a lot of times it's just part of another health problem, and as such, it may not be reported as a separate issue. Mortality rate with known ARDS is estimated at 46%. Again, ARDS is going to occur after direct injury or indirect injury to the lungs, and it usually will occur 24 to 48 hours following that initial injury. The client may initially only exhibit dyspnea and tachypnea, and the breath sounds will be clear because the fluids are located interstitially and not in the airways. And the ABG results may initially be normal, and the chest x-ray will initially be clear. Excuse me. But as the ARDS progresses, we're going to start seeing several different symptoms. We're going to see intercostal retractions and use of the accessory muscles. The respiratory rate continues to increase. Now we see tachycardia. The chest x-ray will show infiltrates. The pulse oximetry and ABG levels will begin to demonstrate hypoxia. The breath sounds will start to have crackles and later rhonchi. Cyanosis will develop and may or may not improve with oxygen administration. Some of the diagnostics that we will do will be ABGs. ABGs are going to start showing a widening alveolar oxygen gradient. Basically, we're increasing the FiO2, so we're increasing the amount of oxygen, but it does not lead to an increased PaO2. The chest x-ray is going to show diffuse haziness or even a whiteout. The chemistry panel will be done to monitor electrolyte levels, and sputum cultures can be done to determine if a lung infection is also present. And an ECG can be done to rule out cardiac basis of all of these symptoms. The priority for the ARDS client is impaired gas exchange and ineffective breathing pattern. The healthcare team needs to initiate interventions to provide adequate ventilatory support, to maintain oxygenation of the client's body cells, and also prevent pulmonary tissue damage. In addition, interventions should be implemented to maintain a patent airway and maintain cardiac output adequate to perfuse all of the body systems. So what do we do for these clients? How do we take care of them? We know that they have a very high mortality rate. So first of all, they're going to require intensive care. They will need oxygen therapy, probably will require intubation and mechanical ventilation. We should position them to improve perfusion. They may require ECMO, the extracorporeal membrane oxygenation, if no improvement with traditional management is seen. If an infection is present, then they will require antibiotics. We should do conservative fluid therapy and diuretics to maintain fluid balance, because one of the complications is going to be fluid retention. We should do enteral or parenteral nutrition as soon as possible. Now, there are different ways we can provide ventilation for ARDS. We can do the CPAP, the continuous positive airway pressure, the BiPAP. We can do mechanical ventilation with assist control, a synchronized intermittent mandatory ventilation, SIMV. We can do pressure support with the ventilator or pressure control with the ventilator, and positive end expiratory pressure, PEEP. So when we do mechanical ventilation, there are specific interventions that we need to follow. Of course, these clients are going to be intubated with an endotracheal tube. We need to initiate ventilator-associated pneumonia prevention protocols that would require keeping the head of the bed elevated at least 30 degrees, administering PIP, doing oral care frequently, repositioning frequently, and suctioning secretions so they don't pool in the lungs. We also need to do DVT and pulmonary embolus prophylaxis. So these clients will be administered an anticoagulant and probably be wearing sequential compression devices. We should monitor the client's respiratory and gas exchange status at least every 4 hours. This will include vital signs, skin color, making sure the endotracheal tube is in the appropriate position, making sure that the cuff is inflated appropriately to keep it in place, and provide appropriate tidal volumes. We also need to monitor the ventilator settings and keep the tubes drained of moisture. Now, when a client is on a mechanical ventilator, respiratory therapy is going to be deeply involved, and they're going to assist with this, but they're not there 24/7, so the nurses also need to provide this monitoring. There is high humidification with the ventilator, so it often will collect moisture, and this moisture can interfere with the settings that are being administered via the ventilator, so we have to keep them drained of moisture. We should assess the client's mouth for skin impairment. As the ventilator settings are changed to go along with the client's status, we need to monitor the client's gas exchange. We should sedate and restrain the client at the lowest rate possible to maintain client safety and comfort. Most people do not tolerate having an endotracheal tube down their uh, throat. It is very uncomfortable and can increase anxiety, etc. They are at risk for accidentally extubating themselves. So, therefore, soft wrist restraints are very common to be used with mechanical ventilation and keeping the client sedated. Again, we don't want to oversedate them, so we do this at the lowest rate possible. Now, there are a few clients that can tolerate that endotracheal tube. And if they are alert, we need to provide for alternative methods of communication. Complications of mechanical ventilation include the hospital or ventilator-acquired pneumonia or other infections, barotrauma, which will be lung damage due to positive pressure and can include situations such as a pneumothorax, cardiovascular effects such as hypotension and fluid retention, gastrointestinal effects such as stress ulcers, malnutrition, and electrolyte imbalances, and gastric distension. Whenever we have that endotracheal tube down, a lot of times air can leak into the stomach and cause gastric distension. Accidental extubation. And if we have accidental extubation, these clients often require re-intubation, and that can cause trauma to the trachea. We have muscle deconditioning and ventilator dependence. As we begin to wean the clients from the ventilator, this will occur after the client's respiratory failure has been corrected or is stabilized. We will usually do maybe a daily sedation trial where we decrease the sedation and see if the client is able to have spontaneous respirations, and if those respirations are adequate, that they are not overtiring the client. We can also do the CPAP or T-piece trials. We not only will monitor the client's vital signs frequently as we're doing these trials, and that will include, of course, the oxygen saturation. We will also monitor the ABGs after a specific amount of time. This is basically going to assess the client's readiness to be extubated. Excuse me. It is also important to have good communication with the respiratory therapist and the healthcare provider. We need to protect that client from accidental dislodgement as we decrease the sedation to make sure that they don't accidentally extubate themselves too early. And again, we need to continually assess vital signs and indications of fatigue. Even after they're extubated, we need to make sure that these clients obtain plenty of rest, that we're not encouraging them to talk. They need to just lay there and sleep. They will have oxygen on at a high flow rate, so in other words, by mask, usually a non-rebreather. And once again, be encouraged to rest as they now take over the work of breathing on their own. And as always, we will evaluate. We need to make sure that that client is maintaining their oxygen saturation at acceptable levels, at least 90%. Their vital signs need to remain stable within acceptable limits and their airway remain clear. Hopefully, that client is not going to experience any complications secondary to hypoxia. And we need to continue to obtain ABGs to make sure that the client's respiratory and acid-base balance has been maintained. So, as always, once we do interventions, we have to evaluate to assure that what we have done has been appropriate, that we do not need to change our interventions.